My name is Bill McCall. I will be announcing the panel off screen. I would like to welcome and thank you to everybody for joining today's virtual briefing. Our host for today's briefing is Drug Policy Alliance. This briefing is being conducted and being recorded on Zoom and is being broadcast live on Facebook by Drug Policy Alliance. As I've mentioned, the briefing is being recorded and all panelists have consented to the recording. Just so that you're aware, if you ask a question, the announcer will use your name and the platform so your name may appear in the recording. The official recording will be sent to webinar registrants. Representatives of the media may be listening to the briefing and may ask questions through the question and answer period. We ask that the media and other participants do not record the briefing themselves. If you wish to make use of clips from the briefing, please be in contact with Grant Smith from Drug Policy Alliance at gsmith@drugpolicy.org. Again, if you wish to make use of clips from the briefing, please be in contact with Grant Smith from Drug Policy Alliance at gsmith@drugpolicy.org. Today's briefing will be conducted as a fireside chat, or rather a moderated conversation between the panelists. For the audience members, there will be a Q&A session at the end of the briefing. Questions will be selected and read by me to the panel. To submit a question, please use the chat feature in either Zoom or Facebook Live. We also want to thank our honorary co-hosts, Congresswoman Pramila Jayapal and Congresswoman Barbara Lee. Now, let's hear first from Cassandra Frederique, the Executive Director of Drug Policy Alliance, and then following that, we will hear a greeting from Congresswoman Lee.
Good afternoon. My name is Cassandra Frederique. I'm the Executive Director of Drug Policy Alliance, the nation's leading organization working to reduce harms associated with drug use and drug policies. Thank you for joining us today for this critical and important discussion about the overdose crisis happening during the COVID-19 pandemic and the essential role that harm reduction providers play in the fight against both public health crises. I want to thank our panelists and extend a special thank you to our honorary co-hosts of today's events, Congresswoman Barbara Lee and Congresswoman Pramila Jayapal, as well as their staff. Thank you so much. We know in a moment where so many people are working, having you join us today for this critical conversation is truly deeply appreciated. You'll be hearing from our expert panel about the tremendous stress that COVID-19 and the economic downturn has inflicted both on people who use drugs and frontline community-based harm reduction providers. The Drug Policy Alliance and our partners work to expand access to life-saving harm reduction services and interventions that help protect people who use drugs from overdose, infectious diseases, and other drug-related harms. Since the early days of COVID-19, the Drug Policy Alliance and our partners have been urging policymakers at the federal level and across the country to not allow the pandemic to distract from the need to respond urgently to early warning signs of a worsening overdose crisis by ensuring that harm reduction providers are treated as essential healthcare workers and given the funding support needed to sustain as well as expand operations. This is critically important as harm reduction has often played a supplementary role in healthcare for people that our traditional healthcare services don't often serve. And so in this moment, when we're dealing with innovative health interventions, harm reduction providers are at the forefront of moving to getting help to people that need it the most. COVID-19 is threatening the very survival of these harm reduction organizations that provide life-saving care to people marginalized from conventional health care systems. We cannot afford to lose these community-based providers during a pandemic and worsening overdose crisis that is devastating all regions of this country, including Black and Brown communities dying disproportionately today from COVID-19, and that for decades have been criminalized by the war on drugs, denied kinder and gentler approaches to drugs often seen in affluent white communities. We must ensure that harm reduction organizations can continue to operate. I want to thank you again for joining us today and giving this discussion the attention it deserves. We are in a moment of extraordinary possibility, and we think that having conversations with our allies are the way forward. Thank you again for joining us.
Hello, I'm Congresswoman Barbara Lee, and I proudly represent the 13th District of California. I want to thank the Drug Policy Alliance for convening this briefing to look at the intersection of the COVID-19 pandemic with the long-standing overdose epidemic. I also want to thank our esteemed speakers who can provide unique insights into the value of harm reduction. Over the last 20 years, nearly 450,000 people in America have died from opioid-related overdoses. New CDC data on overdose deaths tell us that during the first quarter of 2020, the United States experienced a 9.1% increase in reported deaths from all drugs. My home state of California reported an alarming increase of 18.2%, double the national increase. We know that overdose and COVID-19 both disproportionately impact people of color. From 2015 to 2018, overdose deaths among African Americans more than doubled, and almost doubled among Latinx people. Among Indigenous Americans, between 2003 and 2014, overdose deaths doubled as well. And the death rate due to overdose for Asian Americans and Pacific Islanders has also been on the rise, increasing 3.5 times for AAPI men and doubling for AAPI women. As we fight COVID-19, we must also urgently address this rise in death due to overdose. We need to find effective ways to reach people who use drugs, and we need to implement strategies and services to reduce overdose, such as harm reduction, especially during COVID-19. Harm reduction strategies have shown their value in reaching people who are underserved by the medical community. These approaches not only reduce overdose deaths, they also help us fight HIV, tuberculosis, STI, and hepatitis infections. As a member of the House Appropriations Committee, I intend to continue to push for robust funding for harm reduction services. Thank you all for taking the time to learn more about this approach, and I look forward to our continuing work. Thank you again.
Thank you again to Representative Lee and to Cassandra Frederique, the Executive Director of Drug Policy Alliance. We appreciate that. Now, please welcome the moderator for this briefing, Maia Szalavitz, the author of the New York Times bestseller, Unbroken Brain, A Revolutionary New Way of Understanding Addiction.
Thank you so much for having me. I hope, yes, the video is now working. I am honored and delighted to be here and to help moderate this panel. I want to first give a little bit of background on where we are and how harm reduction can help. In the last 20 years, as Congresswoman Lee just said, overdose has killed hundreds of thousands of Americans. We thought we were making progress. In fact, in 2018, we saw the first decline that we'd seen in decades. But unfortunately, that has been reversed. As she just told us, it has increased nearly 10% in the first 3 months of 2020 alone. And that was before COVID hit. We know that the pandemic has been stressful and disruptive for everyone. For people with addiction, it's especially overwhelming, and it's overwhelming the efforts we've been making. Local news reports suggest that the numbers for the rest of the year will be even worse. It is a national catastrophe. Fortunately, however, we do have a way to fight back. And interestingly, it's one that's been given to us by people who use drugs themselves. Harm reduction is a way of thinking about policy that developed during the AIDS crisis and was created by and for people who use drugs. The idea is simple but revolutionary. Basically, policies need to work to reduce overall harm, not just reducing the use of a certain drug or increasing the number of arrests or the amount of drugs that get seized. For harm reduction, what matters most is not whether people are getting high, but whether people are getting hurt. So with HIV, for example, it was clear that AIDS was more likely to kill people than addiction. And that meant that we had to focus on that first and provide clean needles, because dead people can't recover. Today, we face even more with overdose and COVID. Harm reduction teaches us that we need to look at risks in context and recognize that people aren't perfect when they have to change their behavior. Anyone who's ever been on a diet knows this, as does anyone who's forgotten their mask or touched the face at the wrong time or whatever we shouldn't be doing, right? Harm reduction is about putting risk in context and being sure we're most likely to protect ourselves and others when that risk is highest. And it shows what actually helps people change behavior is not shame and punishment, but kindness and encouragement. Harm reduction also suggests that, for example, we need to understand that if you cut off one supply of drugs, like say prescription opioids, another and more dangerous supply will often replace it. So doing this will increase harm unless measures are taken to provide immediate accessible care, both for people with pain and for people with addiction. For policy to reduce addiction and other harms, it has to have this contextual understanding. It has to be practical and meet people where they are, not where we wish they would be. We have a lot to learn from the people who developed the AIDS prevention method that New York State now calls the gold standard for HIV prevention. And that's syringe service programs, which helped bring our HIV rate among intravenous drug users down from over 50% to less than 3% now. With that, I'd like to introduce our panel and talk more about what harm reduction is and why we can all benefit from it. Our panel includes Ricky Bluthenthal, who is Associate Dean for Social Justice and Professor of Preventive Medicine at the Keck School of Medicine of the University of Southern California. We also have Jessica Martinez, who is a methamphetamine services specialist in mobile outreach services at HIPS in Washington, D.C. We have Jim Thacker, the Harm Reduction Program Manager at the University of Kentucky and the Kentucky Department of Public Health's statewide harm reduction initiative. And we also have Michelle Wright, the Interim Director of Policy and Advocacy for the National Harm Reduction Coalition. Dr. Bluthenthal, you've been researching harm reduction for many years. What should we know about it and about how well it works?
Thank you, Maia, for that. So I've been involved in the harm reduction space since 1991. And I think you did a great job of outlining many of the key principles. They include a focus on practical strategies, emphasis on client direction, and then equally important, not being judgmental and not being punitive. What we've observed over the nearly 30 years that I've done research in the space is that when we make resources available to people who use drugs that support their well-being, they will use them as intended, and you will have outside impacts and benefits from them. So we've observed that, as you already pointed out, with syringe exchange programs. And what we know from the literature in that area is that the more that we make clean syringes available to people, there's a linear reduction in their risk behaviors. And we've seen the same thing now with the overdose crisis. So programs beginning in the United States in 2002 began distributing naloxone to people who inject drugs for purposes of reducing overdoses. And should I show the slide now? Can we show the slide? So this first slide shows you MMWR that was published in 2015 that shows the dramatic growth and then distribution of naloxone through largely syringe service programs. These programs were documented to have reversed 26,000 or over 26,000 overdoses in the United States. And you can see how they're distributed across the country. Next slide, please. Since then, we've continued to see growth in overdose education and naloxone distribution programs at syringe service programs. So over 250 now provide these services. And in a recent paper on a project led by Barrett Lambden at RTI International that I contributed to, we saw some impressive positive outcomes from this. Next slide, please. So this is the map of the United States, and let me just take you through it. So there's basically three pieces of data here. So the first piece is the per capita overdose deaths, and darker areas have more overdose deaths. Then you see the circles, which indicate the number of people that we estimate had received naloxone per overdose death in each region of the country. And then finally, the squares show you the number of naloxone doses distributed per overdose death. And so, you know, I think this map shows the need both for federal leadership and also for federal funding. So we have some regions like the West and the Northwest Central area or West North Central area that have both high numbers of persons receiving naloxone per death and high number of doses per deaths. And then you have other regions where both those numbers are quite low. So the East, South Central, South Atlantic, and even the Mid-Atlantic are underperforming. So there's a great need to get the resources, and in this case, naloxone, into the hands of people who use drugs. There's now at this point hundreds of studies documenting that they will use it as intended and that it's a life-saving intervention that we need more than ever now, given the COVID epidemic. And let me just conclude with one last comment. You know, we're really in the midst of what I will call 6 different epidemics as it relates to the health and well-being of people who use drugs. So obviously overdose deaths. There's a national hepatitis C epidemic going on in the United States. There's also a less talked about skin and soft tissue infection epidemic, as well as infective endocarditis related to drug use is growing in each region of the United States. Now we have the COVID pandemic. But lastly, I also want to point out, we also have an epidemic of stigma against people who use drugs. And we really have to stop this. The truth is that the substances that people put in their body does not reduce their human dignity. They are deserving of respect. And as we've documented, has been documented by me and others over the last 3 decades, when folks have the resources that are necessary for their well-being, they will use them and their well-being will improve. Thank you, Maya.
Thank you so much. And I want to just add here that I am myself a person in recovery from addiction. And if harm reduction hadn't provided me with bleach to clean my syringes during the height of AIDS when I was here in New York City, I probably wouldn't be able to be here to moderate this panel. So we really need to value people who use drugs and not just see them as people who are taking things, but also people who can give stuff back. So I want to ask about the situation across the country now. Michelle, what is happening on the national level in terms of the challenges faced by people who use drugs with regard to COVID and overdose?
Thank you, Maya, and good morning from California. As we've heard from colleagues, the data on the overdose crisis prior to and during the COVID pandemic is quite alarming. That data, coupled with the lived experiences that communities who use drugs and engage in sex work face, helps to paint the full magnitude of what we're up against. In New York and California, 2 states that are more well-resourced than a majority of the country in regards to funding and services, collaborations have been built from the bottom up. Community advocates have worked tirelessly for years to educate and engage state legislators, public health officials, and state residents on the real dangers of this public health epidemic, and still, both programs require additional funding to create a replicable and sustainable model. Just this year in California, an unprecedented legislation awarded $15.2 million to help form and support existing syringe service programs. And even those funds are minimal, considering the enormity of the state and what we're up against. The stark reality is that harm reduction is a bipartisan national public health issue that's being dismissed by partisan politics. Prior to being situated within the backdrop of the global pandemic, syringe service providers were underfunded and understaffed. Now, during COVID-19, these programs have taken on the added responsibility of providing numerous wraparound services that government agencies are unwilling to provide, some even out of their own pockets. One reemerging theme across the country is that harm reduction organizations are underfunded. Most groups rely on philanthropic grants, but even that's a slippery slope. There's over $1 trillion in philanthropic funds, and of that money, only 5% is awarded to nonprofits annually, and remarkably, less than 10% is awarded to communities of color. What we've seen are nonprofits developing and implementing solutions that were previously deemed impossible such as take-home methadone-assisted treatment, housing of unhoused residents, and the implementation and expansion of telehealth services. And despite those innovative solutions, overdose rates, as we've heard, are growing, and state funding for direct services are being cut. We need federally coordinated action to implement a COVID mobilization response to take on this public health crisis that has grown exponentially worse from year to year.
Thank you. Jessica, can you tell us what's going on in the Mid-Atlantic? I know you're based in DC.
Yeah, hello everyone from DC. So I just want to talk a little bit about what HIPS does. HIPS provides harm reduction services to clients in the District of Columbia. However, we have many people visiting and calling us from all over, including especially Virginia and Maryland, as they are our neighbors. I want to highlight a few things about our syringe service program. So just last year, from September 2019 to September 2020, we had 6,400 encounters for our needle exchange program. We distributed 393,000 needles, and we also took in about 322,500 needles. HIPS really provides, you know, what I like to think of as like guerrilla harm reduction. We work with people in so many different capacities. When we view drug users or sex workers, as we also work with sex workers, we see the human, we see the person, and we want to empower that individual. And that's why I think our services, especially now during COVID, are so essential. So many people, when we do outreach, and we're doing rolling outreach, come to us and say that they're hungry, that they need meals. And, you know, that's something that I wish we could provide more of, but there just isn't the capacity because of the pandemic. However, I do want to note that we have been tabling, we've been providing clinical services outdoors, and something that a lot of users have been reporting back to us is that they're very thankful that we're still providing these services, picking up needles and going out in the community to make sure that our community stays safe from sharp objects. And, you know, it really is important because when you think about infectious diseases, harm reduction works in infectious diseases. We're combating HIV, we're combating hepatitis, and now we're combating COVID by implementing social distancing, having hand sanitizer available readily for our clients, and also we distributed a bunch of hand sanitizer at the beginning of the pandemic, as well as PPE. I could go on for a lot longer, but I just want to say one last thing is that I think that if we had more funding for harm reduction services, we would be able to get more people in treatment. I totally agree with Dr. Bluthenthal. When you provide people the access to care for themselves, they take it and they make incredibly awesome decisions. And it's so hopeful and amazing to see. And thank you so much.
Thank you very much. Jim, can you tell us about the situation in Kentucky, please?
Well, Kentucky has seen a significant increase in overdoses since the beginning of COVID. The 7-day rolling average is the highest that it has been since we started analyzing this data 2 years ago. So we are seeing a significant increase. In Kentucky, one of the issues, or one of the things where we may have a little bit of advantage is we have the largest number of syringe exchange programs of any state in the nation. And the way that came about was just a few years ago, the CDC came out with a study that they had done, a vulnerability study across the nation after the HIV outbreak among the PWID population in Austin, Indiana. And they identified 220 vulnerable counties in the nation in over 26 states. Kentucky has 54 of those 220 counties. We have 7 in the top 10. And so I've been asked why Kentucky and how Kentucky has moved so quickly in such a short period of time to institute syringe services programs. Well, if necessity is the mother of invention, crisis is the father of action. Kentucky has some of the highest hepatitis C rates in the country. We have really high overdose rates. We know we're vulnerable to HIV infection and cluster outbreaks. And so that was really the impetus for public health officials to go to local officials, because it is based on each individual county and city governments here in Kentucky for them to pass resolutions allowing syringe services to operate within their county and city. So we did a lot of education, and that's sort of how it came about. Now with COVID, we've had to adapt. We've had to take services outside. We've had to start doing HIV testing and hepatitis C testing in tents, those kinds of things. Of course, cold weather's coming, and that's going to create problems for us, because we've got to find a way to bring those services back inside, because we can't stop testing. We can't afford to trade one disease for another.
So how is the community reacting to this expansion in harm reduction?
It's mixed. It really depends on the community. There are some communities that have embraced it wholeheartedly. One of the things that we see is that when our folks start working with the faith communities and get some of them on board, and then start educating the public and doing grassroots work to educate county officials and city officials, things go well. Is there opposition? Absolutely. There always will be a certain segment of the population that's not happy. But it is a continual process of education and keeping people informed about why they're needed, how they prevent the spread of communicable disease, and how they don't enable drug use, which is always a huge question if we're going into a new county to try to begin a syringe service program.
Right. No, we've always had that issue around people thinking that that giving clean needles will make people want to use drugs more. And what's amazing is that the reality is so different, because people who use drugs are so stigmatized and so marginalized, and people are so cruel to them most of the time, that somebody being nice to them just shocks them. You give them a clean needle and you say, I want to save your life. They're like, what? You care? And that often enables all kinds of things, such as recovery, not using.
I agree. They're the most appreciative population I've ever worked with, because the smile that you give them when they walk into a syringe service program, you may be the only person that smiles at them that day. Because quite often they don't have support systems. They don't have that social network. And so we provide not only the sterile syringes to help prevent the spread of disease, including HIV, hepatitis C, endocarditis, and all those different diseases that we see associated with injection drug use, but we also become trusted services to them, so that we can refer them to people who are willing to take care of those issues, medical services, because these people do not have good histories with medical services. And if we refer them somewhere, they trust us that they can go there and not face the stigma that they may face somewhere else.
Let me turn to Michelle now. What gaps are you seeing nationwide in funding for these necessary services?
Sure, thanks, Maya. Yeah, there are definitely gaps. Yeah, there's definitely gaps. And the short answer is that we need funding. We need federal lawmakers to act. And the real truth is that the COVID-19 pandemic is highlighting a well-known issue in harm reduction communities, that people who use drugs are disposable. And without those wraparound services that some of my colleagues named, that they engage the full humanity of our communities, testing centers and linkages to care, people are continuing to die at an elevated rate. And we're here today in a unified voice to ensure that organizations working directly with people who use drugs, people who engage with sex work, and utilize HIV and hepatitis C programming are funded. Specifically, we're asking for $58 million through the Center for Disease Control's Opioid and Infectious Diseases program in the next COVID-19 response package, and for $58 million in the fiscal year 2021 appropriations bill. We've heard nationally that harm reduction providers are not receiving COVID-19 relief funds locally, and there is no federal funding stream dedicated to supporting harm reduction. That means that those life-saving services aren't being delivered to those who are relying on them, and that each day organizations, underfunded and understaffed, are making the decision whether or not to provide services like syringes or naloxone, asking staff to pay out of pocket for protective equipment, and turning away participants who may have nowhere else to go.
Right. Can anybody else speak to the need for funding and for what is most needed and most urgent?
I would share with you that local health departments, which are the seats of syringe service programs in Kentucky, did not create their budgets for this year to include the PPE that we're having to use. And so that is a hole in the budget. They're suddenly having to purchase all this PPE and hand sanitizers and those kinds of things to provide to their staff, as well as masks to the participants who come into the programs. That's eating a hole in the budget. Also, in order to bring the services back inside, some of them very likely are going to have to reconfigure their physical space in order to adapt to the situation with COVID. And the money's simply not there to do that.
Right. I'd like to ask the panel about the disparate effects of COVID on communities of color and on the criminal legal system. Ricky, I think you may have some data on this.
Well, I have some impressions on this. So one of the things that we've seen in Los Angeles in particular is, of course, COVID has been spread rapidly in the criminal justice system. And in LA, that's disproportionately brown and Black people. So you have that kind of impact. And even though they've done, I think, a fairly good job of trying to de-densify the local jails, they've returned people to communities without adequate support, housing, and access to resources, which further facilitates the spread of COVID. So I do think that and then we have these ongoing epidemics, right? I mean, at one point, and I haven't tracked this on a daily basis, but at one point in Men's Central Jail in LA County, something like 40% of the people in there were quarantined. We need systematic solutions. One of the things that's nice that's going on in LA County is that there's a real effort to develop a robust system of alternatives to incarceration, which could help us both with people with substance use disorder, severe mental illness, and people who get, relatively minor charges related to substance use or for being poor. For instance, a lot of people end up in jail because they're unhoused and are trespassing in an empty building, for instance. So we need to create a whole system, social structure that is going to provide support for people so that they can be safe and in community rather than unsafe and incarcerated.
Michelle?
Sure, I'm happy to expand on some of what Dr. Bluthenthal shared, but obviously this question is very weighty. Historically, the healthcare industry and criminal and justice systems have not been designed for Black, Indigenous people of color. And this year, the national dialogue has coalesced around the continued murders of Black and brown folks at the hands of violent law enforcement agents. Our communities have and are being constantly surveilled, profiled, targeted, and penalized by the criminal justice system. Imagine with me, Damon's a college professor who's struggling to make ends meet due to the COVID-19 pandemic. He lives with 2 roommates who judge his drug use and have warned him that they'll call the cops on him the next time he uses. After another exhausting workday, Damon turns on the television, and once again, the images that he sees are bleak. He's manic and needs to self-medicate, but he ran out of syringes, so he'll need to venture out to access supplies. These drugs are the only thing that allow him to cope with the weighted day-to-day impact of trauma. So he heads out, visits his neighborhood syringe service provider, and because he can't head home, he goes to the park around the corner to shoot up. Now from here, the scenario could go a number of ways. Damon could face someone in the park who doesn't like his drug use and they wind up calling the cops. He ends up in the system. He's alone, which elevates his risk of a fatal overdose without anyone there to provide the life-saving naloxone treatment, should he need it. The cops could arrive and are unwilling to use naloxone on him because of stigma, and they've labeled Damon as just another junkie. Damon could use, allow the drugs to take effect, and then go home. And whether you agree or not, these types of decisions are being made daily in cities across the country. The difference between outcomes is dependent on various factors. Damon's employed, has shelter and access to clean syringes, but for many individuals who use drugs, this is not the case. Who will fight for those who lack representation in these conversations? Especially for Black trans and gender nonconforming folks, STEMs, and communities of color who have been systemically targeted by law enforcement agencies, it's exhausting. Productivity is low, stress levels are elevated. We're deemed essential and must decide between staying home or going to work to support our families. We're bombarded without an end in sight. So this shelter-in-place ordinance has only magnified what Black and brown communities have known forever. Racism is a pandemic, and we need a new plan of action. In the absence of the transformative overhaul that we're not going to see probably anytime soon, we need to fund systems that ensure we have access to clean syringes, naloxone, employee assistance programs, including affordable testing, medical and mental health care, systems that are reflective of our community's needs, and policies that account for those most impacted by systems of oppression.
Thanks. So do we have any questions from the audience?
Thank you, Maia. Yes, we do have a number of questions that have come in. I'll just ask them directly if that works for you.
Yes.
Adam from the Office of Senator Markey in Massachusetts submitted through the registry a question about medication-assisted treatment. Basically, it boils down to what changes are needed to make medication-assisted treatment more available.
Can I answer that?
Sure.
I would like to jump in and say what we need to do is get rid of all of the regulations that exist on methadone and get rid of the X waiver for buprenorphine and allow physicians to prescribe the medication they believe will work for their patients. We don't need extra regulations for people who use drugs that are not there for people in pain. And we were already crushing people in pain in many other different ways because of our overdose crisis. So what we really need to do there is deregulate this stuff in a sensible way and get the DEA out of healthcare.
Does anyone else want to answer that? I saw a lot of nodding heads.
Well, you know, one of the things that COVID has done with the telemedicine has really made it a lot easier for people to get medication treatment, particularly buprenorphine. And I know at LA County USC, we've made some great strides in getting buprenorphine to homeless or unhoused people who use drugs in the last couple of months. And it's because of this sort of loosening of the regulations. The other thing is, and someone brought up this point about the role of pharmacy, is that, you know, we and I'm not sure what the mechanisms or levers are, but we definitely want to come up with some ideas about how to get pharmacists to carry buprenorphine, and then also to routinely honor prescriptions. So there, I guess, in the professional practice of pharmacists, they have some leeway about what medications they can give out to people. And we've had reports from individuals who have, you know, valid prescriptions for buprenorphine, and pharmacists not filling them. So obviously, they wouldn't withhold diabetes medicine to someone. They shouldn't be withholding buprenorphine to people who need it.
And there's also been prosecutions by the DEA of doctors for prescribing buprenorphine right at the time when we want to get as much buprenorphine out there as possible. Every time somebody takes buprenorphine instead of heroin, which is contaminated with fentanyl, we have the possibility of saving a life. So the idea that they're prosecuting the treatment providers, in fact, the former head of the American Society of Addiction Medicine, makes no sense in this context.
I'm going to move on to another question. Chuck with the Education Development Center at the PTTC also submitted at registry. Can you comment on strategies for contactless naloxone dissemination? So does anyone have contactless naloxone dissemination strategies?
So one interesting thing that I've done with my clients recently is if I get a call for a delivery and I'm doing a syringe exchange, I will kind of tell someone, like, let's meet up in this open space. And then when I see the person, like, I'll be on the phone with them, I'll drop off the thing in my view and then take 6 feet away and then let that person come and pick it up. So I never have to be within the distance of that person, but they're still receiving their syringes, their naloxone, their Narcan, and I'm watching it. I'm making sure that no one else is messing with it, and then I watch to make sure no one messes with them. but you know, they're able to go and get it without us having an interaction face to face. I also think that like if you have a mobile services van, you can take chalk and you can actually chalk on the sidewalk a line for people to like wait, and then you could set it down and they can like move up. So that's one method that I recommend.
Thank you. The next question is from Monty, who's a board member with the Ostrich Bay Exchange in Kitsap County, Washington. He asks, what is being done in this time of crisis and change to start to shift the paradigm in which more people die from stimulant overdoses versus opioid overdoses in his state? So no matter how much Narcan they distribute, overdose deaths will continue until the paradigm of how we deal with drugs in this society moves to a public health model. And so Monty's asking for what can we do with that?
So I'll be very brief. I like study this, I work on this, like, you know, methamphetamine injectors are like the main focus of what I work with. And something that I'm seeing when I'm doing outreach with clients is I'm seeing a lot more polysubstance use. And I'm not sure if anyone else can speak on polysubstance use from injection users, but that increases the risk of a fatal overdose. So unfortunately, Narcan or naloxone will only reverse a fatal overdose for an opioid user. It won't work for a stimulant user because that usually looks like a stroke or a heart attack. So something that I think harm reduction strategies for that I've seen in academia have been like, you know, recommending that users use safer smoking kits or using pipes and trying to reduce their injection use or reduce the amount that they inject. So on a barrel, like if they're filling it up halfway, which would be 0.5, maybe instead of doing a 0.5, doing a 0.3, and in, you know, trying to reduce the use. I think something, especially in the mid-Atlantic region, that I'm noticing is that since there isn't a stable drug supply because of the disruption of COVID, people are accessing more and more powerful methamphetamine. And I'm not even sure where it's coming from. I can't even pinpoint it. I don't work in law enforcement, so I don't know. But the methamphetamine that they're getting is more powerful. So something that I'm recommending is use less and then see how you're feeling and then engage with the substance for users. That's what I recommend.
Thank you. I'm going to try to combine. Oh, go ahead. Sorry.
I just wanted to reemphasize that the polysubstance use has always been around. So let's be clear about that. So forever. So that's not new. But data that I've collected with my colleague Alex Kroll in San Francisco and Los Angeles, what we've seen looking at changes in substance use patterns over the last 30 days, looking at two different samples of people interviewed 5 years apart, is that we've seen basically a doubling in the amount of meth use, a 3 to 4 times increase in combined use of meth and heroin. So people injecting with both a mixture of heroin or fentanyl and methamphetamine among the heroin user, among the people who inject drugs. So I just want to make the point that there's a polysubstance use has always been around, but there's a lot more of it that's gone on in the last 7 to 8 years, and we're poorly equipped to address it because we don't have the same kinds of medications for meth use that we do for opiates in terms of treatment. And so we're going to have to begin to get a lot more creative. And I'll just throw out the, obviously 2 areas that are responsive to the question. So one is these safer consumption rooms. They can work for meth people who are using stimulants just as they work for folks who are using opiates, and create a space where people aren't going to be at elevated risk for infectious disease spread because the place is clean, they have clean materials, and then they're observed. So if there's a problem, there's someone that can provide a medical response. And then I think the other thing is safer supply. So there's great rigorous studies of heroin-assisted treatment that have been conducted in Canada, that have been conducted in Switzerland and elsewhere in Europe, that are very, they're rigorous, they're very promising. And what happens is that when people are put in a paradigm where they have control over their drug use, it turns out the drug use goes down. And the other parts of their well-being increase. So people begin to get employed, people are more consistently housed, people begin to get occupational training and rebuild their lives in a way that the current system really doesn't allow.
Thank you. We've got questions coming in like popcorn, so I'm going to try and combine a few. We got Gina and Stephanie from Zoom asked about how can programs get funding for syringes? That that they're running out of funding in Milwaukee. Also, there's a related question about fentanyl testing strips that federal funding can't fund. And then further related is where can we find funding for Peer Street outreach, syringe exchange supplies, and PPE? Do folks have secrets about finding funding?
Not a secret, perhaps, but it just does allow for a deeper conversation around philanthropic funds, which I started to talk a little bit about during my statements. Is, you know, we are relying on these philanthropic dollars to fund qualitative deliverables as opposed to like meeting the needs of our communities at a time when COVID-19 as well as additional like endemics are upon us. And so we need to have a really tough conversation around funding streams around philanthropic dollars and reroute the deliverables to include more humane approaches like the ones just named.
I also think there's an opportunity, given that there's all these lawsuits against the opioid manufacturers, and that's a source of money that's going to eventually be a very large source of money. And so harm reduction programs should not forget about that as a place to be looking.
Thank you. One question that did come up was, can we repeat, is there more information about the federal harm reduction request and how folks can get involved? Can we clarify that there's a COVID-19 package ask and separately an FY21 appropriations ask?
Michelle, I think that one's for you.
I actually think that one's for Bill, probably.
Oh, sorry.
Maybe I will say, so I have been working quite a bit with Drug Policy Alliance on this. There are two separate requests that are out there now. I think one of the things that we're finding is that there probably needs to be a separate harm reduction request that is very specifically about harm reduction, and that would begin to fill in the gap. And frankly, at this point, we need to scale up harm reduction. I'd even say that we should ask in the billions. But in the meantime, we have been working with the AIDS Budget and Appropriations Coalition, as well as hepatitis advocates. And there is very specifically a request for a total of $58 million in the fiscal year 21 appropriations bill. That bill is currently being put off until after the election, and they'll resume negotiations on it. And we do intend to work to include that $58 million. In the meantime, at the same time, there are several COVID packages that have been proposed. We'll know very soon whether they're able to actually pass a COVID package bill before the election. No matter what happens, we'll continue to ask for funding. Right now, that ask is for $58 million. But again, I think what we're hearing is that this is an incredible need, that the gaps are many, and that we need to be asking for more funding than that. So hopefully that answered people's questions a little bit from off the screen. We do have a further question from Sandra Gold about whether there are programs that do things to reduce stigma and to increase humanity. And then I'm going to turn this back over because I think we're very close to our timing on this. I'm turning this back to you, Maia.
Okay, sure. I just want to say about stigma, like there's lots of good efforts. I have actually worked on one called Changing the Narrative, where the idea is to change the language that we're using. So we talk about people who use drugs, not addicts or junkies. So that we talk about medication treatment, not medication-assisted treatment, since we don't have Prozac-assisted treatment for depression. So that we really get our language in line with believing that addiction is a medical problem. And speaking of that, the number one thing we can do to destigmatize it is to decriminalize. Because the whole point of criminalizing something is to stigmatize it so that other people won't do it. When that is not working, all you're just creating is a lot of stigma that is just harming people. So I will throw that out there. And now I'd like everybody to give us their final closing thoughts on what you would like people to take away from this. Let's start with Joe.
Once again, is the idea that while we are in a global pandemic, we all understand that, we cannot afford to trade one disease for another. We can't shut these harm reduction services down where we aren't regularly testing people for HIV and for hepatitis C, where they're not getting sterile syringes and needles and they're contracting endocarditis. I will tell you, in 2019, the University of Kentucky Healthcare saw 400 cases of endocarditis, and 75% of them were people who inject drugs. And that's just at that one hospital in Kentucky. That isn't covering University of Louisville and Northern Kentucky and the Pikeville Hospital, where we see the same sorts of problems. So it is imperative that we have the funding to keep these harm reduction services open and able to provide all of the services that we normally provide versus scaling back because we simply don't have the money to do it. Just remember, we can't trade one disease for another.
Thank you. Jessica?
I think my biggest takeaway for everyone in this conversation is that harm reduction pays for itself. When you get people in treatment, you get people in recovery, those people can go back and be productive members of society. But to assume that people need to produce in a society that doesn't really provide any services for them, any ability to have housing, have secure housing, stable housing, fair housing, a stable job, these are things that my clients want, that they earnestly want. And, it's my belief that if we wouldn't stigmatize drug users so much and would just reach into the wonderful services that so many people, especially on this panel, are providing, we would be able to change what our communities look like. And for HIPS, what that would look like in DC is being able to provide 24-hour harm reduction services. If we were able to provide people needles every day at any time of the day, or a space to come in and get tested, talk to someone, have some counseling, eat a meal, or just sit. I've been a shoulder to cry on for so many people. And sometimes that's just what people need. It's just a little bit of love, to be reminded that they're loved. And to everyone who's watching, if you're a drug user or if you've been a drug user in the past, I know I've struggled with addiction, and that's how I got into my work. And I just want to say that you are important, you matter, and you are loved. Thank you.
Thank you. Michelle.
Thanks for that, Maya. So legislators and staff, we need champions like you to support our funding ask for $58 million in the fiscal year 2021 bill and for $58 million in the next COVID-19 package. Not only are we working against systems that often overlook and stigmatize our folks, people who use drugs and people who engage in sex work, but we're working against communities emboldened by this administration who don't care if we die in the streets. As federal lawmakers, you have the ability to deliver critical funds now to organizations that are already trusted and ingrained in communities across the country. Let part of your legacy include ensuring that harm reduction organizations have the ability to reduce the loss of life from drug overdoses, to provide preventative testing services, and to offer hope during one of the most challenging times in our nation's history. Love to the many that we've lost this year. We continue to fight for you. Thank you for your time, consideration, and support.
Thank you. Ricky?
Yeah, let me just conclude with 2 points as one of the research people on the panel. We have, over the last 30 years, we've amassed an impressive number of empirical studies supporting both the principle and application of harm reduction for well-being of people who use drugs. So we know what works, let's support it. The other thing I just want to share is, from that long perspective, is there are also political fights that need to happen at the local level, and that we need to engage federally at the state level and in your city and county to also support these programs and recognize that they're part of the solution, not the problem.
Thank you. I would just like to say that we should all recall that harm reduction is not just about drugs and substances. It can be a philosophy that can allow us to deal with all kinds of infectious diseases and all kinds of problematic behaviors. This is a gift from people who use drugs to the rest of the world, a way of helping people manage risks in context. If you just take one risk and you don't have the context, you may end up causing a disaster. Harm reduction allows us to look beyond that and say, wait a minute, if we take away this, somebody else might do that, and then that would actually be even worse. When we look at the context and when we recognize how this can work, and we can see how everything from naloxone to needle exchange to all of the other harm reduction practices that we have used and that are proven to work, we can expand that out. And we can now see places like the Washington Post and the New York Times talking about, we need to do harm reduction for COVID so that we're not all driving ourselves crazy by locking ourselves in the house 24/7 and not doing anything because we cannot take any risk. Risk in context is really important, and these are essential services that will save lives of people that we love, so please help.
So I think that brings us to the end. Is that correct, Maia? Do you have any final things? Otherwise, I'll go on ahead and do the wrap up here.
Yes, I think that's it. Thank you so much.
Very good. So thank you very much to our audience for coming and participating in today's virtual briefing. We greatly appreciate it. Thank you also to our wonderful and expert panel, Ricky Bluthenthal, Jessica Martinez, Jim Thacker, and Michelle Wright. I'd like to say a special thank you to Maia Szalavitz for doing such a wonderful job with moderation. We appreciate that. Thank you also to Congresswoman Barbara Lee and to Congresswoman Pramila Jayapal, who were the honorary co-hosts of today's briefing. Finally, thanks especially to Drug Policy Alliance and especially to Cassandra Frederique and Grant Smith, who organized today's event, and also thank you to Collier Collective and their staff for creating the event. Finally, a reminder that a recording of today's event will be shared with anyone who registered via Zoom. Again, we thank you all for participating in today's virtual briefing. Congratulations and thank you, everybody. Bye-bye.
Bye now.